There's nothing that excites me more than learning new things and teaching new things, which is why I love the field of venous and lymphatic medicine, because there's so much to learn. So the therapeutic modalities on the horizon for treatment of superficial and deep venous insufficiency. I'll start with the superficial system. We'll cover newer MOCA modalities, some different radiofrequency technologies. I have Indian glue on there, but unfortunately, my friends here aren't going to go to India until next week, so I really don't have much on that, but I'll get back to you when they get back from India. So I'll start with the newer MOCA modalities. The ones that we know is Clarivane, made by Merit Medical. For that technology, we have a rotating arm with a blunt tip that damages the endothelium, while a sclerosant is a liquid sclerosant, usually STS, sodium tetradecyl sulfate, is injected. The newer technology, which is available in Europe, called Flebobrif, is a technology similar but with foam and a little bit of a different endothelial damage. It is an over-the-wire or Seldinger technique, and it's almost like a Cook catheter. I don't know if you can see my pointer here, where this device is passed through the catheter, and there's almost like a hook on each of these little projectiles. The device is slowly pulled back while those hooks scrape and damage the endothelial wall. And there is a foam rather than a liquid sclerosant that's injected into the vein, causing the endothelial damage. This was invented by Piotr Ciostek. Did I get that? And he's from Warsaw, Poland. It's passed through a 5 French catheter, and it's got those 5 curved springy wires with the sharpened ends on them. In his first study with 40 patients, at 1 month, there was near full occlusion with a 97.4% occlusion rate. 6 months and 12 months were about the same at 89.7% occlusion. On here, I did not see any results of VCSS or any quality of life study, so this was strictly an occlusion. All right, so in the second study with 200 patients treated, the initial success rate at 3 months, or initial success at 1 month, was 100% occlusion, and at 3 months, 96%. So very good results with this newer technology. At 12 months, with all of their studies, they had an average of 92% occlusion rate. As far as radiofrequency technology here in the United States, we currently have Medtronic is the one that we use. Different RF technologies in Europe, the RFITT, or Radiofrequency Induced Thermal Therapy. This device is very similar to an endovenous laser in that it's a fiber with a small 18 millimeter tip to it. So rather than the 7 centimeter or 3 centimeter length tip, it's 18 millimeters. So it can be used in smaller segments. It can be positioned up to 1 centimeter inferior to the junction. Now, based on what we just heard from Ken, I don't know that that really matters based on the studies, but it can be placed in perforators also. Now, this technology is similar to what we currently use in perforators in that it's based on impedance. The tip heats up to 100 degrees Celsius, and it is a constant pullback like we have in our laser technology. You set or preset the impedance, and there's an auto stop mechanism on it. So that gives you the flexibility to deliver however much energy you feel that vein needs at that particular point, depending on the diameter. So you have that flexibility that you have that people like with the laser technology, but you have it in a radio frequency format. The only problem is I'm hearing, because I don't have any direct experience with this, but the auto stop technology on here I hear is quite annoying, because it does stop frequently. So it is a pedal-operated device. Now here you can see the tip of it is blunt, just like the normal radiofrequency catheters. There are hash marks on the fiber itself, so you can see where you're at. And you can see the tip of that right within 1 centimeter of the junction. And this is the generator for the device. So it can be set at bipolar or monopolar, so you can use this for endovenous ablations, but it can also be used for cutting and cottering. And the success of this is about 98.4% complete occlusion rate. I believe that is at about a year. So similar to the radiofrequency technologies that we have here, but different uses. I'm gonna glance over this F-Care system. This is another type of radiofrequency device that's available in Europe. Very similar to the one I just told you about, the Olympus device, except this one has multiple tips that you can use either for surface veins, like spider veins, rosacea on the face. You can use it with monopolar cutting, or you can use it for endovenous ablation, which, to quote Dr. Morrison, means that it doesn't do any of those well, if it can do all of them in general. But I don't have any direct experience with this, but you can see that these are the tips, the needle tips that you can use to cauterize facial veins. The catheter for the endovenous ablation is very similar to the RFITT, and it also is a 6 French, and it's got a 5 millimeter tip, or 5 millimeter diameter tip. So the one I'm most excited about is the one technology that is currently under investigation for deep venous reflux, autogenous valve creation. So that theory is not new. So we have other technology or open surgical procedures where we can create autogenous valves. But this blue leaf endovenous valve formation system is a minimally invasive way to do that, rather than having to resort to open surgery. Intervene is the company that makes this, and it's the first ever developed endovascular device. It doesn't require open access. Blue leaf is inserted into the vein, and it does the same type of surgical procedure as the Mileti neovalve procedure, forming autogenous valves out of the endothelium. So we've got some pictures here that I'll show you. This is the Intervene device. It's got a cutting tip to it that will then cut the endothelium and create a pocket. Currently, what we have to treat deep venous reflux includes treating the superficial system, stenting any obstructions in the deep system, and then short stretch bandages. Other than that, like I said, the open surgeries. So deep venous reflux linked to ulcer disease. In deep venous reflux, ulcer C456 disease goes up. And so does ulcer recurrence over time when you have deep venous reflux. So you can see that tip cutting the endothelium. It hydrodissects the endothelium away from the wall. You can create a monocusp or a bicusp valve. There's a nitinol dissector that goes through once the hydrodissection takes place. It's the use of IVUS while you do this procedure. You can also do multiple valves in one setting, and just as in situ, you can see the valves are formed in a helical pattern. You can make multiple valves in a helical pattern. So there you can see the IVUS pushing the endothelium away. And all of this is done percutaneously. And that's just the hydrodissection. So that's a monocusp valve, and then you rotate it to do a bicuspid valve. The studies on this, and I'll just quickly say this and wrap it up, but they standardly do 7 days of low molecular weight heparin, followed by 6 months of a NOAC. They've had good success in their 7-month trial. This is very early stages, so if any big, CVM center is looking to do a study with these guys, they are doing second phase trials right now. This is the cadaveric tissue, so you can see what it looks like in real life. But they have 0 DVTs with this procedure in 7 months.